And good morning, everyone, and welcome to another series of the training for EMTCT, which is organized as a way to strengthen the overall primary prevention and treatment services for HIV, syphilis, and hepatitis B. In 2025, and earlier this year in February, we concluded the training on HIV. And today we start a new series which will focus on the elimination of the mother-to-child transmission of hepatitis B. We are happy that you are able to participate in this session today. Today we will have a presentation by our colleague from PAHO, Dr. Leandro Sereno, who will present on the screening and the clinical management of pregnant women for hepatitis B, and also it will be followed by a presentation from Turks and Caicos as they present on the country experience as it relates to their screening and treatment of pregnant women for hepatitis B. I must take this opportunity to say that Turks and Caicos has since applied to PAHO to be validated for the elimination of hepatitis B, given that they have in place all the elements to advance. They have since done so, and to date, the country has been they have submitted the application form and it has been approved by the Regional Validation Committee. I just want to remind before we go into the session also that this training, these virtual trainings that we have been doing since last year, is a part of the regional project, which is aimed for the strengthening of the EMTCT services within maternal and child health, which is funded by the Indian Development Foundation, to which all the CARICOM member states and territories are beneficiaries to the grant. So thank you very much for taking this time out to participate in this training today. It is very much appreciated. Just before I turn over to the first presenter for today, I just want to remind that your mics are muted, and we will go through both presentations before we open for questions, comments, or any interventions that you may have. At that time, you'll be able to open your mics and make the intervention. And so without further ado, I will now turn over to the first presenter for today, Dr. Leandro Sereno, who is the advisor for hepatitis, for viral hepatitis from PAHO headquarters in Washington. Dr. Sereno, over to you, and thank you very much for taking the time out to participate in this training today. I turn over to you.
Okay, thank you. Good morning, everyone. It's a pleasure to be here presenting on viral hepatitis and the strategies and the recommendation for the elimination of mother-to-child transmission. As Sandra mentioned, this is a series of 2 webinars. Today, we're going to focus on the management, the screening and management, clinical management of hepatitis B during pregnancy. And for the next webinar, we are going to focus on the recommendations and management for the children. So we'll be discussing the immunization, the immunoglobulin, and then the treatment and follow-up of the exposed and infected babies in the next webinar. And today we'll be focused on the pregnant woman. But I would like to start by giving an overview of the epidemics and then some of the overview also on viral hepatitis and some specificities of the hepatitis B, the chronic infection versus acute infection, followed by the screening and then clinical management, and in the end, the prophylaxis when a woman has no recommendation, no eligibility for treatment. Let me share my screen. Okay. Okay, I hope you can see my screen well, and I hope also the audio is good. Let me know if there is any issue with that. I will just turn off my camera while presenting so we don't have any connections, issues with the connection. So, uh, so as I mentioned, I would like to start by a quick overview on the burden of the hepatitis B, at the both global and the regional level. As we've seen here, we estimated almost 250 million people living with chronic hepatitis B at the global level. No? We can see here, comparing to the other regions, now that the region of the Americas, we have a relatively lower burden of viral hepatitis B comparing to other regions, like, for example, Africa region and the Pacific region, they have a very higher burden for hepatitis B, but we are still talking about 5 million people living with chronic hepatitis B infection in the region of the Americas, and that's sustaining the transmission, especially a good proportion of these 5 million are women of reproductive age and that will get pregnant, and there is a real risk for the transmission to their babies, perpetuating the transmission of hepatitis B in our region. And second, okay, and okay. And hepatitis B at the global level is one of the diseases, I think one of the only disease that we can see that we have an increasing mortality over time. Based on the estimates that were developed by WHO, we have seen a reduction between 2019 here and 2022, with the world has observed a reduction of the new cases and new infections on hepatitis B, and mostly due to the immunization programs that we've seen being implemented across the world. But we can see here that is, I think, among of the only few diseases where you can see an increase in mortality, raising from 800,000 to little over 1 million people dying every year for hepatitis B in 2022, the estimated for 2022. And that's basically the result of a limited access to diagnosis and treatment. People are being diagnosed very late in the course of the disease with cirrhosis and liver cancer or fibrosis of the liver, and then there are limited access to treatment, as we are going to see. So we need to also beyond now think about hepatitis beyond the ANC, beyond antenatal care, beyond we really need to scale up interventions for viral hepatitis, especially hepatitis B, as we see the mortality is increasing. And specifically for the region, as I mentioned, 5 million people across the Americas living with hepatitis B. Half of these people half of these people is living in Latin America, and around 700,000 people in the Caribbean. We still, of course, there may be some concerns regarding these numbers because they are estimates based on data that is publicly available, but the primary information, the primary source of data is very limited, especially in the Caribbean. We don't have many studies or serological surveys on hepatitis B, so that makes these numbers well, but still the best numbers that we have, the numbers that we have available, and they are good enough for starting planning and responding to the viral hepatitis. But still, almost 1 million people living with hepatitis B across the Caribbean region. As we've seen, as I mentioned, the access to diagnosis and treatment is very limited here across our region. Among the 5 million people living with hepatitis that we estimated, only 20% are aware of the status of the diagnosis, and even 20% of those have access to treatment. No? And here in the color of the bars, we can see that in red here is the Caribbean region. We see that this proportion is even smaller for the Caribbean. Now we have even fewer people aware of the diagnosis in the Caribbean and even accessing treatment. I just put here hepatitis C for comparison. We have the same situation, similar situation. So the viral hepatitis, chronic viral hepatitis in general, we have a very limited access to interventions here in the region of the Americas and also in the Caribbean, something that we need to address and need to be responded, especially when we look at the mortality rates for hepatitis B here in the region, the total burden here. So the mortality rate for liver cancer, cirrhosis, and other chronic liver disease caused by hepatitis B, most of the Caribbean countries, we can see that they are either increasing their mortality. We have a few countries that are either reducing or have stabilized the mortality over the past few years. This is based on the estimates by the Global Burden Disease, and we have the latest available data is for 2021. So maybe after that, we could see an improvement because countries are responding more, but also we may also have seen some impact of the COVID-19 pandemic, even disrupting the services, the limited service that were available. But overall, most of the countries, we are observing an increase in the mortality, flagging the need to address and to respond to this. And as we're going to see, one entry point, one starting point to respond to viral hepatitis B is through antenatal care and focusing on pregnant women and their babies. And WHO has a series of documentations and guidelines and recommendations on how to address, how to implement national plans for viral hepatitis B. We are going today here focusing on the hepatitis B guidelines that was published by WHO in 2015 and recently updated in 2024. So that's a very, fresh new recommendations that we are also working to disseminate across our region. Mm-hmm. So first, I'll start with some overall definition of viral hepatitis, some features and characteristics of this disease. So we define hepatitis by an acute or a liver inflammation that can be caused by a variety of causes, and including alcohol, drugs, medicines, infections, of course, different sources of infection, bacteria. And there is one specific group of viruses that we call the hepatotropic viruses that can cause infection of the liver and damage the hepatocytes, and then they are called hepatotropic viruses, and that's one of the most causes of hepatitis, now the viral hepatitis. And here is the most common, or at least 5 currently known hepatitis, viral hepatitis, or virus that cause viral hepatitis, hepatitis A through E. They are not a single group of viruses. They are different families. They are viruses from different families, different groups of viruses, but they share one characteristic, one feature, that they have preference for infecting and injure the liver. That's why they are grouped together in the name, but they are completely different viruses with different dynamics and even a different progression of the disease and treatments and etc. So we are going today focus only on the hepatitis B virus. Following the infection, so the clinical presentation, they have 2 different phases: the acute viral hepatitis, which is the inflammation of the liver that's happening following a recent infection with a hepatotropic viruses. And all of the viruses from the previous slides, A through E, they can cause this syndrome, the acute viral hepatitis. That's very short, can last from days to weeks. And there are 3 clinical marked phases. Now, the prodrome, which is very unspecific, symptoms, fatigue, fever, vomiting, etc., that lasts for a few days, followed by the icteric phase, which is what traditionally marks marks the viral hepatitis. Now that includes jaundice, very characteristic now viral hepatitis. That's the jaundice, dark urine, pale stools, and etc. that can stay for a few weeks. And then the convalescence period where there is a gradual recovery that can take several weeks to be fully recovered, the liver and the patient. The investigation includes the assessment of the liver disease, the liver damage, so we can understand also the prognosis, imaging tests, especially the ultrasound, to see how it's going. And also it's very important when you have an acute hepatitis to do a panel of viral serology to try to identify the specific etiology of the disease, to identify each virus, if it's a virus, to identify each virus is causing, because we're going to see there is going to impact on the clinical decision. And for this phase, the management is just supportive. There is no specific treatment, but we need to be aware that to monitor the patient and seek for signs and look up for signs of acute liver failure or fulminant hepatitis, which is a very dramatic situation that needs very intensive response. But otherwise, and that's very rare compared not to acute viral hepatitis. It's very supportive care, no? And for this, well, all the viruses that I mentioned, they A through E, they cause acute hepatitis, and some of those, especially hepatitis B, C, and D, they can evolve into chronic infection, which is defined by the presence of the virus infecting the liver after 6 months of the initial infection. No? And the problem here is that the virus is in the virus is in the liver, and that they continue and they maintain an ongoing hepatocyte injury with gradual healing through fibrosis. And later on, additional damage to the liver, followed by healing through fibrosis. And then with time, this liver is going to be fibrotic and then evolve into cirrhosis. And that's the main problem that will lead to liver failure in the future. And the problem is that mostly these infections, the chronic infections, they are mostly asymptomatic for many, many years, revealing themselves when the patient has already some liver failure. Now they have cirrhotic or even liver cancer with some of the signs of liver failure, including jaundice, of course, portal hypertension with ascites, varices, and etc. So we need to be aware of this. And the idea is, of course, to identify and diagnose the patient with chronic hepatitis B before they reach this stage. So that's why it's important to screen everyone, even without clinical symptoms of hepatitis, because as I mentioned, it's mostly asymptomatic after the initial infection from the previous slide. The hepatitis B, the viruses, here is just an overview. We're not going to the details of the structure of the virus, but there are different components of the virus, and each of those components, they have some seromarkers, now being antigens and also antibodies, and they have different levels of these markers across the course of the infection, the progression, the natural course of the infection. And that will be very important to define, well, first to diagnosis, so we can understand and differentiate if it's a current infection, acute chronic infection, or if it's a past infection or protection. We are going to see that in a few moments. But also they are very useful to monitor the patient and also to determine and to define eligibility for treatment. So here's just a quick description of each of those seromarkers. Now, so the most important here that I would like to highlight is the surface antigen, the HBsAg, or the hepatitis B surface antigen, and that's the hallmark of infection. Meaning that if this antigen, if this serological test is positive, it means that the person has a chronic, or I'm sorry, an active infection of hepatitis B, and then it can be combined with others to identify and to define if it's a chronic, acute infection, chronic infection, and etc. But if you have the surface antigen, then you can define that's active infection of hepatitis B. And then the other markers is to define where and the stage of the disease. And also there is not here, but you have also the DNA or the viral load, the HBV viral load, which will be also important for eligibility of the for treatment, but we are going to see that in a few moments. No? And as I mentioned, acute and chronic hepatitis, they have a different profiles, no, the levels and the titers of these different markers. They behave differently depending on the dynamics. Some for the acute infection, uh, here showing that after exposure and after the course of the acute infection, the disease is resolved. No, hepatitis B, the surface antigen here negativates because there is a spontaneous clearance of the virus. But in many cases, especially for children here, they evolve to chronic infection and the surface antigen is going to be positive for life. And in the future, they may reduce, but they'll be very positive uh, for life. So, and here just to demonstrate the different levels, so you can use the titers of this test to identify the stage of the disease. No, and so the most used are these markers, but again, just to show that if the person has no positivity for any of the serum markers, the person they had never been exposed. If they have the HBsAg positive, then they have infection. It's an ongoing infection, active infection. If they have the IgM antibodies, they can be on acute infection. If the anti-8BC is positive, could be, I'm sorry, if the IgM is negative, could represent a chronic infection, but also we need to understand to cross this with the epidemiological information on the date of exposure, if it's available, and etc. And also another test that is important here is the anti-8BS, that's the serum marker that indicates protection, immunity against hepatitis B. And that could be due to past natural infection. And then you have at least an additional marker positive, which is the antibody anti-8BC, but also can be positive due to vaccination, especially for healthcare workers that we need to confirm if they are protected after vaccination. We use the anti-HBs test, no, to check the serology, to check for the response of the vaccination. And as I mentioned, in the cycle of liver damage and healing through fibrosis, back and forward, then the liver progress. Now there is a progression of the liver damage, the liver disease, going from fibrotic to cirrhotic, and in the end, the liver can develop a liver cancer due to the infection of hepatitis or viral hepatitis B and C, of course, but we're talking about B here. And this progress of the liver disease is classified using the METAV stage, which is initially and originally assessed through a liver biopsy. But we are moving from the biopsy now for the past few years, and we have very good non-invasive methods to estimate the liver, the stage of the liver fibrosis, because that's what we're going to see is very important for treatment eligibility, but also for prognosis of the patients. So regarding testing, what I think, as I mentioned, we need to work to identify, to diagnose these patients before they evolve to more advanced liver diseases. So, and testing is at the core, of the interventions for viral hepatitis B and also for hepatitis C, but most of this also would apply for hepatitis C as well. But the testing is the entry point. So we do a screening for hepatitis B, and that's the graphic that has been adapted from the HIV, and also very similar, the dynamics here, the concept. It's just that the testing is at the center now of the care. You test the people, and here we're talking about pregnant women. If the test is negative, then you can refer the patient, you can link them to the prevention cascade. And for hepatitis B, we have the vaccine. So let's say during antenatal care, you implement universal screening for hepatitis B for pregnant women. If the woman is negative, then you can vaccinate that woman. You can counsel them And you can include and provide general prevention, general information, assess the risk for infection, etc. I can inform the patient about the risk for hepatitis. And if the patient is positive, then you need to link them to care. You need to do the assessment of the disease, treatment eligibility, and then to treat, of course. And the objective here is to suppress the viral load and suppress viral replication. No? We are going to see that in detail. So the entry point here is the testing, which is at the core, no, of the interventions. So in the recommendation, we're talking about pregnant women, but we need also to think beyond that, because we have the specific additional groups that may be affected by hepatitis and could benefit from that. And how do we test? You know, how is the testing for hepatitis B as recommended by WHO? It's here in this box below. But you test it with a serological test, and as I mentioned, the surface antigen. Now that's the initial test that is done, and could be done either with ELISA test at laboratory or rapid test, which is also recommended for some implementation for practicality and also for the point of care and very quick turnaround time to identify and to report the results for the woman. And following this test, if the test for serological test is positive, then we need to do a molecular test. You know, the viral load that is going to define the levels of the HBV DNA, which is not to confirm infection, as most of people think. The infection is confirmed only through the surface antigen, but the DNA is to guide treatment. No? And then if it's positive, then you need to link to care. You have some considerations also for the expansion, like for example, as I mentioned, the rapid test for point of care. The viral loads also can be done through gene experts, and then we've seen most countries now expanding the networks of gene expert machines, especially for TB and HIV, that could be leveraged and also included the cartridges for hepatitis B for this test, and also some other interventions that could be used to scale up the screening of hepatitis B, especially outreach activities. No? And that's why I'd like to mention, because most of the countries, several countries, they usually have a very passive policy in terms of hepatitis A screening, hepatitis B screening. Some have defined universal screening for pregnant women, which is very important, but for other groups, that's very passive and only on clinical recommendation. And that's something that needs to be reviewed. WHO has a recommendation for for active seeking after screening for populations that may be highly affected by hepatitis B infection, or may suffer a specific or more stigma and discrimination or special vulnerabilities, like specific geographic areas, indigenous populations, all the key population that's also affected for STIs and HIV. They should be also assessed and tested for hepatitis B and hepatitis C as well. Like, for example, as part of the PrEP programs or HIV combination prevention strategies should also include hepatitis B testing as well. But here today we are focusing on pregnant women, and the idea is to have it more active and universal screening for hepatitis B, but also considering to expand this strategy to other groups as well. And here, just to show that when services, when systems, when they implement active search for cases and they try to expand the testing for hepatitis B, they identify people. And even more, for example, when in this revision here, several studies in 56 countries, I'm sorry, and 14 million, when they integrate, oh, I'm sorry. Here, okay. And when they integrate the hepatitis B and C test into the HIV screening program, they will identify more people with hepatitis B and hepatitis C than with HIV. Now, for every 3 people diagnosed with HIV, another 4 with hepatitis B and 7 with hepatitis C were identified in these 56 countries, including here pregnant women. Now, when they started, I'm sorry, I don't know what's happening here, but yeah. even well, they expanded for pregnant women. They identified the testing for hepatitis B. They were able to identify more cases than the HIV, which is their original targets. And also another meta-analysis here demonstrate the different strategies that works for identifying and scale up the screening for hepatitis B, showing that it's important to have some more active and outreach activities, as I mentioned earlier, because the strategies that demonstrated the most impact on scaling up is for working in the community, offering the testing in the community, either through the community health workers, no, and also community testing, putting, especially with the support of civil society, to include stations for screening in the community. That were the two main most impactful strategies to scale up this screening. No? And once the woman is positive, you perform the test, and now here these recommendations will be focusing on pregnant women, but they are mostly applied to every patient that has been diagnosed with chronic hepatitis B. So following the initial diagnosis, surface antigen that is positive. What is the initial step? The first step is this initial assessment, and this assessment, I mean, can contain two components. The first one is to assess the treatment eligibility. Now, we are going to see that not all patients with chronic hepatitis B are eligible for treatment at the moment of the diagnosis. So we need to identify the patients that will respond better to treatment. And that includes staging, identifying the stage of the liver disease. As I mentioned, using non-invasive assessment. We have several one. I'm going to mention the next slides. We also need to check the liver enzymes, both ALT and AST, and also the levels of the viral load for hepatitis B. And also need to check for medical history and family history as well. For example, co-infections with other viruses, comorbidities, family history of liver cancer, and cirrhosis, because that's also going to impact on the definition and the criteria to initiate, to recommend treatment. And the second component is more general measures. Of course, we need to recommend against the use of alcohol, and then to maintain a quality diet for preventing further metabolic damage to the liver. We need to assess the adherence to check if we recommend treatment, this patient will adhere to the treatment. And also you need to think more, also need to consider the prevention transmission, need to interrupt the transmission, thinking about other household members, sexual contacts, screen the other the other children of a pregnant woman, the previous children of a pregnant woman that is positive, the partners, and if they are negative, including the woman, they should be vaccinated. No. Yeah, should be vaccinated to prevent the transmission. So for the non-invasive, as I mentioned, the liver biopsies, which is has for years has been the gold standard, is very unpractical in many settings. It's very invasive. You need a surgeon to do it. So in many cases, in many places, it's not available. And to avoid this and to overcome this barrier, several tests, non-invasive methods have been implemented. WHO recommends basically two. It's most recommended these two that are most common, which is the APRI, is the aspartate, the AST platelet radio index, using only serological tests or basic serum tests, and applied to this formula. And this ratio, this index, if you have a number of higher than 0.2%, or that indicates fibrosis, and higher than 1% indicates cirrhosis. And that's the recommended test, non-invasive test, and they have very high sensitivity and specificity to identify if a patient has a significant fibrosis or cirrhosis that will indicate and recommend treatment. The other test that's also recommended is based on imaging testing, is elastography, the FibroScan, which is basically an ultrasound that can measure the liver stiffness. And the problem, not the problem, but since you need equipment and specific training for the performance of this test, maybe it can be a cost barrier in many places. But when where it's available and where the cost is not a major constraint, it's also recommended. But as I mentioned, there are several other tests that could be used, and also with different levels of complexities. But WHO recommends these two basically for most public health implementation. And the rationale for that is to select the patients that will receive treatment is mostly because, as you can see here, the incidence of outcomes of especially the cancer, cirrhosis, and also liver-related deaths related with the infection, they are more frequent, and the incidence of these outcomes are higher the higher the viral loads of the person has. Like here, for example, you can see that as the higher the viral loads, the risk of cirrhosis increases, the same for cancer, the same for overall death or liver-related death among these patients. And similarly, the incidence of this disease is lower when the patient has normal levels of transaminase, specifically here the ALT. So you need to measure the ALT and then the DNA, HBV DNA, to identify the risks for this patient developing in the short term or the cirrhosis cancer or even die due to the infection. And additionally, there's also a very strong evidence, or there is some evidence demonstrating that the treatment has a better efficacy when initiated at higher viral load and ALT base levels. No, so the patients, they respond better to the treatment when they have higher viral load or higher ALT, and that's why these serum markers are being considered for recommendation of treatment, even though we are observing now a scale up now, flexibility on the recommendations, on the criteria to recommend treatment, because there is also some emerging evidence showing that earlier treatment may also be beneficial, even if they do not have this higher viral load, higher ALT levels. And that's also guiding, and the perspective is that in the future, these recommendations will be for even a wider group of patients. But overall, what WHO recommends in terms of eligibility, who are we going to treat for hepatitis B? So the recommendation is to treat people, adults and adolescents, including pregnant women. So pregnant women here have the same recommendations for treatment. If a patient has a significant fibrosis higher than F2, regardless of the levels of the DNA and ALT, as I mentioned. So if there is liver damage, you need to treat regardless of any other factor. Or if there is a high viral load and high ALT, so this, regardless of the liver stage of the liver disease, so if you have high viral load and high ALT, you need to treat. And also, just one comment here on pregnancy, as we know that during pregnancy, the ALT level can normalize, so maybe not the best test to assess this during pregnancy. So it's very important that following the pregnancy and the postpartum, the woman should be reassessed to confirm the eligibility for treatment. Special situations like co-infections and history family of liver cancer, as I mentioned 2 slides ago, regardless of any other factor, if any of this situation here is present, then the patient should be treated. And in the end, even if you cannot, if you don't have any, if you're working in a setting where the DNA is not available and you cannot identify the stage of the infection and where, if the patient has a eligibility based on the viral load, then if the ALT, because it's a basic test, most of settings will have it available. If the ALT is persistently abnormal, then the treatment is also recommended, regardless of all the other factors here. So that will be 4 main criteria for eligibility, and then we are expected to have at least at the global level, around 50 to 60% of the patients at diagnosis will fit into this criteria. And the other percent will make the deferred treatment for that moment and continue the follow-up. Okay, so after you define the treatment eligibility, so here on the right is the algorithm from the guideline. So you did the initial assessment, you did the evaluation regarding treatment eligibility. So how do you treat? Now, if the patient is eligible for treatment, how to start treatment? The preferred regimen is tenofovir. Now, tenofovir is the recommended with the one that we have the best response and is widely available in most settings. So that would be the preferred regimen. The entecavir is also an option as a preferred regimen. If you're working in settings where you don't have the monotherapy with tenofovir and only have the fixed dose combination with lamivudine or anthracycline, mostly because of the HIV drugs that are used for the HIV treatment, there is no issue. And then these medications can also be used to treat people with hepatitis B. There's been no the efficacy is maintained. It's safe to treat people with hepatitis B with this fixed dose combination. So if the country has no single dose monotherapy, single presentation for tenofovir, they can consider these combined medications. Okay. And also, if there is the situation and specific situations, because we know that tenofovir have some toxicity regarding kidney and also the bones. So we have some alternatives, especially the newly introduced TAF, not the tenofovir alafenamide, that could also be considered for treatment in these situations. And then finally, when we start treatment, the treatment in these situations here, when the patient is eligible for treatment, is a treatment for life. So you need to start monitoring several components. Especially, you need to survey, do the surveillance for cancer, especially if the patient has cirrhosis. So every 6 months, you need to do ultrasound and alpha fetoprotein dosage, so we can check if the patient has you need to identify very early on the incidence of liver cancer. For all patients, you need to do all the tests from the initial assessment every year at least, testing the ALT, testing DNA, doing the non-invasive fibrosis assessment, and very frequently reassess the adherence to treatment. And also, finally, you need to monitor for safety. As we mentioned, the tenofovir has some toxicity regarding regarding kidney and then bones. So here in on the algorithm that I mentioned, initial assessment, treatment eligibility, start treatment, and monitor. But then you see here on the right that, as I mentioned, 40% of the patient, 50 to 40% of the patient, they will not fit in any of the treatment eligibility criteria, and then we may defer treatment. So this patient will be, they will have the treatment defer, and then will be monitored annually for the initial test, as I mentioned earlier. But what happens, what to do when a pregnant woman is not eligible for treatment? So she is not eligible for treatment for her own health, as we've discussed. She does not fit in any criteria. So what to do for that specific woman? And the rationale and the question comes and rises specifically because we know, talking specifically about the transmission of mother to child of hepatitis B, we've known that the interventions that are available, specifically the vaccination, the birth dose, and the 3 doses in the first year, and also the immunoglobulin, they reduce the risk of the infection and the transmission from the mother to the babies from the virtually 100% to around 7.5%, no, 7 or 5%, when you add all the interventions. And the literature also shows us that these protections is even more important, and these interventions are more efficient when the woman has low viral load. No, so if you have high viral load, there is this levels of protection, and if the woman has lower viral load, then there is even further protection, and can be a protection of almost 99%. So, based on this, the question was what to do. Is it worth and it's important to reduce the viral load during pregnancy, even if the woman has no treatment criteria for their own health? How to do it? And based on the literature also show us that they were able to identify the levels of the viral load in which the transmission starts happening. You know, like for example, for all the studies that were available, this meta-analysis showing that there's been no transmission from mother to child in women with viral load below 200,000 units. Of course, if you consider and if you add all the other interventions, now the immunization, the immunoglobulin, etc. So transmission started with viral loads higher than 200,000 units. So that's why this threshold has been defined. If the woman has no eligibility for treatment, then you check the viral load. If it's higher, then you could consider start tenofovir for that woman. And it's effective. Yes, the literature also, this systematic review show that the use of tenofovir has a reduction of 84% now on the transmission of mother to child on the mother to child transmission of hepatitis B, among infected women, showing that it can increase and further reduce and further protect the babies from the infection of hepatitis B. And it's also very safe, of course. Tenofovir, we have a long history of tenofovir during pregnancy due to transmission of HIV. So has been very safe and with no harmful maternal or infant effects during the studies. And another question that may raise is that, as I mentioned, not everywhere we can find the viral load, to demonstrate, to identify the women that we need to implement the prophylaxis. So in those cases, then you can use the e antigen. That's one of the seromarkers that we mentioned earlier. And also systematic reviews have demonstrated that they have high sensitivity and high specificity in demonstrating and estimating the viral load of women. So if the antigen is positive, is most likely that this woman have viral load higher than 200,000. And then if you don't have viral load available in your settings, in your services, you could use an e-antigen to recommend treatment. So and based on this evidence, the WHO is recommending now the prophylaxis. So the first step is to define if the woman is eligible for treatment. If not, then you recommend you can check if she's eligible for prophylaxis. And then, as I mentioned, DNA higher than 200,000 or e-antigen positive, then you recommend it. But then if you are in a place or a setting that you don't have either the DNA or the antigen, the e-antigen is available. In your setting is not available, and that happens a lot. So in that case, you may consider to start prophylaxis for all pregnant women, because we've seen that the benefit for reducing the viral load is very important to prevent the transmission for the baby. And then you start the treatment, the prophylaxis, during the second trimester, and then you can maintain until delivery or until the babies, the infants complete the vaccinations until the 6 months of age, when they complete the vaccination series, the three doses. So just a summary, I'm just going to conclude my presentation. I'm sorry, the slide is not showing well, but we can follow here. So the integrated pathway of hepatitis B in antenatal care. So universal screening. We need to screen all pregnant women for hepatitis B. If the woman is negative, then you can linkage and offer the prevention package. Now you need to counsel to reduce transmission. You can vaccinate the woman and then vaccinate the contacts as well. As we mentioned, we need to all the package, and also plan for timely birth dose for the babies. If the woman is positive, you need to assess for the treatment eligibility, as we've discussed. Now, the stage of the liver disease, levels of ALT and DNA, clinical history, and etc. If the woman is eligible, you then start treatment. And then you start treatment with tenofovir, and then monitoring every 6 months or every year, depending on the criteria. If the woman is not eligible for treatment for their own health, then you can consider prophylaxis. If the woman has a viral load higher than 2,000, If the viral load is not available, you can use the antigen positive to indicate as a proxy of high viral load. If neither is available, then you can consider treating all pregnant women with chronic hepatitis B, starting tenofovir as a prophylaxis during starting the second trimester and going through the liver and the postpartum, especially after the babies conclude the vaccination. And for the exposed babies, we are going to discuss in the next webinar. We need also to consider immunoglobulin. You need to consider the birth dose in the first 24 hours, and then complete vaccination, and also the testing at the end of the first year to confirm that the baby was not infected, and to estimate and to calculate the mother-to-child transmission rate. And for all babies, regardless of the exposure, we need to also to implement the birth dose, universal birth dose at the first 24 hours, and also to complete the vaccination, the 3 doses during the first year. So this is my final slide. So we just need to think about some of recommendations that countries in the Caribbean, especially since we are discussing here today, what they can do to accelerate the progress now toward the elimination of viral hepatitis or hepatitis B in that specific case. Now, hepatitis B, as Sandra mentioned, has been incorporated now as part of the MTCT Plus to leverage the experience of HIV and syphilis. But we just need to remember that it's not a verticality, it's not a vertical initiative. It needs an interprogrammatic work. And also, since most of the countries here have very very high political commitment to the MTCT of HIV and syphilis, we can leverage on that political commitment to also to include on hepatitis B. No? We also need to expand the birth dose coverage as a strategy to protect and to reduce, to further eliminate the transmission of mother to child, but also the hepatitis as a public health problem, expanding the services through antenatal care, the screening of the woman, offering the testing and the treatment or prophylaxis for the women that are positive. And also very important, since we're talking about elimination, we need to demonstrate the impact of these strategies. And although countries may have a very robust information system to demonstrate and to monitor the indicators for hepatitis, for HIV and syphilis, there's still very limited information regarding hepatitis and hepatitis B specifically. So we need to strengthen, the countries need to strengthen the data reporting systems to include and to generate the data to demonstrate the coverage of vaccination, immunoglobulin for exposed children, testing and treatment among women, and also the follow-up and the outcomes of the exposed baby. So these are some of the recommendations, especially here on the data that we've seen that is very limited in our region. As we're going to hear now, there are countries already working and already demonstrating the impact of the implementation of these interventions, but we need to work on to improve and to start progressing, advancing, and scaling up these interventions if we want to achieve the elimination of the MTCT. Yes, thank you. Thank you. Back to you, Sandra.
Thank you very much, Leandro, for that excellent and very thorough presentation detailing the screening and treatment of pregnant women for hepatitis B, and also while reminding us why it is important to screen and treat pregnant women in a timely manner, not only timely, but appropriately, as we strive to eliminate hepatitis B as a public health threat in the Caribbean. And the strategy and the EMTCT strategy is one of the ways that will get us there. Thank you very much again. We will hold questions for Leandro until after we have the country experience from Turks and Caicos. And as I said before, Turks and Caicos has implemented primary prevention program within maternal and child health for hepatitis B for some years now. They have all the elements in place as outlined by Leandro, and using their programmatic data, they were able to apply for the elimination of the mother-to-child transmission of hepatitis B, which so far has been successful. And so, here to share the experience with us today, we have Dr. Clarke, who is the Director of Health Promotion and Advocacy Unit for in Turks and Caicos, and she has been very instrumental in leading and advancing the national validation team for HIV and hepatitis B in Turks and Caicos. So, Dr. Clarke, I now turn over to you for you to share the country experience and any lessons learned that you would like to share with the audience today. Thank you very much.
Thank you so much for having me today. Allow me to share my screen. Sorry, let me go again. Is everyone able to see my screen?
Yes, we're seeing the screen.
Okay, so thank you again for having me. As Ms. Jones mentioned, I am the Director of Health Promotion and Advocacy Unit and the EMTCT focal point for Turks and Caicos Islands. So I think to completely understand the experience of Turks and Caicos Islands, I think we should have some perspective of what Turks and Caicos Islands is or where we are. So we are a British overseas territory country. We are located within the Bahamas archipelago. Our population estimate, according to CIA World Factbook, as of 2024 was 60,000. We have 40 islands and keys, 8 of which are populated. We have one hospital system called TCI Hospitals, and we have 2 locations at Providenciales and Grand Turk. Those are 2 of our major populated islands. We also have 8 government-operated clinics, most of which have a midwife and or a public health nurse. And about a third or more of our population is from migrant country, but when we add everything up, quite likely it's going to be more than that. Important to note is that about 95% of all of our antenatal clients are seen within about 90-95% are seen within either the government-operated clinic or within the hospital antenatal clinic. And 100% of our births are linked to the hospital. There are no birthing centers, and we have nominal to no births occurring on the outer islands. And if it does occur, they are actually sent to the hospitals within 6 hours. All right, so let me walk you through what it is for us in terms of screening for antenatal clients. We are still paper-based within the clinics. We use the CLAP form to register the clients and do testing. Importantly, we offer universal hepatitis B screening for our mothers, and it is offered at their first antenatal visit. And they have 2 levels of screening that occur here. We actually offer venipuncture, a central sample that has been happening since 2001, and results from that are within 24 to 72 hours. And although we are paper-based within the clinic, the tests are requested via electronic system to the hospital, so the results return to us electronically, and that comes back to us within 24 to 72 hours, depending on your location within the islands. Importantly, also, because of the geography of the country, and we only have 2 hospitals, and testing is actually done at 1 hospital setting, we saw it necessary to implement point-of-care testing for all of our pregnant mothers in 2003. So we offered point-of-care testing for HIV, syphilis, and hepatitis B for these pregnant mothers. Importantly, of course, we have to make sure that we're doing pre- and post-test counseling so they know the importance of the investigations that we're offering to them. They understand what the results are. And so whenever we get back the results, there's acceptance of the results, and then we can move on with next step as part of forming a rapport with our pregnant mothers. So for the floor chart for us for hepatitis B testing is that at the first postnatal visit. We offer both testing. If they are negative, then they continue until third trimester where we offer our repeat testing. And these are for the mothers that are presenting in the first trimester. Of course,
Excuse me, Dr. Clarke, you're breaking up a bit. But maybe you could turn off your video for a while.
trimester that you're presenting, we also offer testing.
We're not seeing your screen. Hello? I'm not certain what happened if we lost Dr. Clarke. Give me 1 second while I see if I could get her. I am thinking she must have lost service because I'm not able to hear her. I guess in the meantime, until we could get Dr. Clarke back online, perhaps Leandro, would you be able to take any questions in the interim?
Yeah, sure.
Yeah. So I'm sorry, we're going to be making a deviation at the point in time. I saw a message came in that says Dr. Clarke was bumped off. So with that, until we are able to connect to her again, or she's able to connect to us, I would like to open up for any questions that anyone may have for Leandro at this time. Please free to make your interventions, comments, or questions. So the floor is now open to the audience.
You can also write your questions in the chat if you prefer. That'll be awesome. Okay.
Let me see. I see a question in the chat that says, how should pregnant women who present at delivery be dealt with as it relates to hepatitis B? That is a question. Leandra, do you want to take that?
Yeah, so in terms of the screening, if the woman arrives at delivery and has no records that she was ever in contact with antenatal care, you need to do the screening. But at this moment, there is no recommendation to initiate or start any prophylaxis or treatment during labor, during delivery, because there is no studies on that demonstrating any benefits. So, but the screening, if it's a part of the algorithm for the pregnant woman in your settings, in your service, then the testing should still be offered. And because you'll be able to identify that woman positive and then to offer the baby the immunoglobulin. In addition to the vaccine, to the birth dose in the first 24 hours, and then the follow-up vaccination, you also can offer the immunoglobulin to this exposed baby. And then, of course, in the postpartum, we are going to continue the assessment of the mother and then to confirm if she is eligible for treatment or not. There is no, I mean, the treatment is also recommended, could be recommended during breastfeeding. There is no anything against it. But in terms of recommendation directly related to the delivery, is the screening, and if it's positive, the immunoglobulin to the baby, because this baby is now an exposed infant.
Okay. Thank you very much. I see that we have a hand raised. Wandra Wallace, do you have a question for Leandro? If you do, you could go ahead and unmute yourself, please.
We can't hear you. I'm sorry.
Yeah, the person is muted. If you have your hand is raised, so if you have a question, please go ahead and ask the question.
Hi, morning. Sorry about that, Ms. Jones. My internet.
Right, yeah, just give us 1 second. We were just taking some questions in the meantime. Well, I guess there's that person does not have a question. I have another question here, and it says, excellent presentation. I have a patient in late second trimester with positive hepatitis, normal LFTs, no symptoms, negative, viral load is delayed. We are trying to get the results. Should I go ahead and start TDF while waiting for the hepatitis B viral load? That's a question.
Yes. So yeah, thank you, Nikia, for the question. I think in that situation, you have a patient, we don't have the viral load yet, but then we've discussed you can use the e antigen as a proxy for the higher viral load patient. And if it's negative, then perhaps it's not recommended. But then the same recommendation, the same guideline says that it could be considered for all pregnant women. Maybe in this case, for prophylaxis, may not be the most beneficial because there is a negative HBE, even though you don't have the viral load. So that will be more on a case-by-case decision. You can discuss with the patient if she would adhere to treatment, if she desires to receive the treatment. That could be on the individual case-by-case decision, because we've seen that there is, as I mentioned, there is a trend on expanding the eligibility criteria beyond the ones that WHO is recommending, because there are some benefits that have been demonstrated when we start earlier. No? And in the case of treatment for her own health, for this woman, she has normal liver enzymes, and you're still waiting for the viral load. If you don't have you can do the APRI and see if there is any level of cirrhosis, if the APRI is higher than 0.1, so you can use the liver, the AST, and platelets to calculate it. So if there is no recommendation, there is no sign of fibrosis, in the end, you could still decide because you don't have the viral load, and then the viral load could be I mean, as we've seen now, if you don't have the test, you could consider treating everyone. But maybe in that situation, to be a case-by-case, a shared decision, informed decision with the patient, but maybe the benefits will not be the highest in that specific context. Because especially for prophylaxis, maybe not recommended because the e antigen is negative. But yeah, I think I would still consider, but discussing with the patient. Did I answer, I guess, the question? And in terms of the other question that I see, what the risk ratio of hepatitis B in the Southern Caribbean? And that's one of the things that I mentioned earlier during the presentation. We have very limited information regarding hepatitis, viral hepatitis overall in the Caribbean. Now, based on the data that we have on the estimates, the Caribbean could be consider a hotspot for hepatitis B. Some countries report prevalence around 1% or even higher, 2%, which is relatively low prevalence. The region overall has lower prevalence, but then when you compare to other regions, especially in the Amazon, maybe the Amazon countries, they have higher prevalence, especially among indigenous populations for hepatitis B. But still, for the Caribbeans and specifically at the country level, we have very limited information. And as you're going to see, and we're hearing Dr. Clarke saying that we have several countries now testing the pregnant women and testing partners and start testing people. So we expected that the information on hepatitis B is going to be improved, and we have better assessment now on what's happening in the Caribbean. Over. I'm sorry, Sandra, back to you.
Yes. Okay, thank you very much. We have Dr. Clarke online, so we will hold the additional questions for the time being so that she could actually go ahead and make her presentation. So Dr. Clarke, you could go ahead and share your screen and continue.
Are you seeing my screen? Ms. Jones?
Yes, we're seeing the screen. Sorry.
All right, so let me just, where was I? I'd already given you the background of within the Turks and Caicos Islands. So for our antenatal clinic, we are still paper-based, as I mentioned earlier. We're using, well, I'm not sure what you heard. We still use the CLAP form for registration. And importantly, here on the Turks and Caicos Islands, we practice universal screening of our hepatitis B, of our pregnant mothers. Hepatitis B testing is offered to all pregnant mothers, and we're offering testing at 2 levels. So we're collecting a central sample also, but we're also offering point of care testing. And this is because of the geography of Turks and Caicos Islands. There is one testing site within the country for hepatitis B, although we have 2 hospital sites, but only one of those 2 sites actually offer testing. And so if we are able to get information early enough on the mothers by using the point of care testing, then we'll know what direction we're going with in terms of assessing her for treatment and or prophylaxis for those clients. For our clinics, for our central sample, we are able to access results within 24 to 72 hours. And although we're paper-based within the clinics, our test results are actually requested from the hospital through an electronic portal. So we send the request electronically and we get the results electronically as soon as they're available. It's important for us that we are doing pre and post test counseling for the individuals to make sure that they're aware of what we're testing them for. We're reducing fear if the results come back positive, and increase acceptance of the results for the clients. And so it makes it a much smoother process for us to make sure that pre and post test counseling happens for the clients. So walking you through the testing process, hepatitis B flow, for the clients, they're offered their testing at first antenatal clinic visits. If it's negative, then they go on to get tested again in the third trimester. And that particularly happens because we are not sure of the risk of reinfection or infection for our clients. So we offer testing again at third trimester. If they are indeed positive, importantly, within the TCI hospital system for the central sample, reflex testing occurs for hepatitis E antigen or hepatitis viral load or hepatitis B DNA testing is not actually done in country, and that's why there's an asterisk. There's actually sent overseas, and those results we're not able to access within 10 to 14 days. But reflex testing occurs on every single sample that is actually positive. And for those meeting the criteria for treatment or prophylaxis, then tenofovir is offered for free. Importantly, for those individuals that present to our clinic that have not had antenatal clinic, present to the hospital for delivery that have not had antenatal visits, hepatitis B testing is done on them, along with HIV and syphilis within within an hour of presenting. A sample is collected and they're able to access the results for that if they present at that hospital that offers the testing. Within 6 hours for that hospital that doesn't offer the testing, rapid point of care testing is available for them, so they have that results available to make the decision on what next to do with the infant or with the mother in this instance. Importantly, for those individuals who are accessing antenatal care in a timely manner, we are informing the hospital that they are positive. They're also referred at 36 weeks. I mentioned earlier, I'm not sure if you're able to hear, that about 90 to 95% of pregnant mothers within the Turks and Caicos Islands actually access antenatal care within the government-operated clinics or at the hospital antenatal clinic, and that's the high-risk clinic. So we're able to ensure that we're coordinating so that they're aware of what is happening with the mothers. All of their results are sent with them. And again, because of the electronic portal, the information on the antenatal mothers are sent through this portal. So it's sent electronically, so they're aware of all the investigations that are being done on them. Also, there is the care card from the Clarke card that is also taken to them. Importantly, for these infants that have been exposed, we offer universal hepatitis B birth dose, and that has been just commenced in 2019. Importantly, the public health nurses visit the labor and delivery unit every day, and they offer the hepatitis B birth dose, and our figures have been 100% in terms of acceptance up to 2024 of the birth dose that is there. Also, for those, and so it's off, the birth dose is offered to all infants, but specifically for the hepatitis B exposed infants, immunoglobulin is offered to all of these infants, and the hepatitis B vaccine is actually kept on the labor ward specifically for those hepatitis B infants, and the pediatrician will administer it, along with hepatitis B immunoglobulin at the same time. Importantly, for these infants as well, we ensure that they're getting their full vaccination coverage series, and we are offering them testing at 9 to 12 months old, about 3 months after the last vaccination here in the Turks and Caicos Islands. And just briefly looking at some data from the TCI, as I mentioned, we have 100% testing of all of our pregnant women. 100% of our exposed infants are receiving their immunoglobulin and their birth dose. These are the numbers for the country figures for the third dose. And of course, for those exposed individuals, exposed infants, they receive 100% of their continued series of vaccination. So what do we see as our strengths within the Turks and Caicos Islands for the program? Our strength is that we offer universal screening. There's point of care and central laboratory samples that are taken. Screening is conducted at the first booking. All women are tested, and even if you present in labor, you are screened at that time. And we do a repeat testing at third trimester. We are able to request electronic or lab test results. There's reflex hepatitis E screening done. I didn't mention before that at our largest antenatal clinic, booking clinic, and this is at one of the hospital sites, we actually have a phlebotomist on site that is collecting the blood to make sure that the central sample is collected. And importantly, the two largest sites for antenatal care in Turks and Caicos, the government clinics are actually on the same complex as the hospital, so it kind of streamlines processing. Within the clinical management, tenofovir is available for all eligible pregnant mothers, whether it is for treatment or prophylaxis, and it's offered for free within the government system. All pregnant mothers are referred to the hospital at 36 weeks. All 100% of deliveries are linked to the hospital, and I say linked to the hospital in terms of all of who have physically delivered in the hospital, and if they're born on the outer islands, they're sent to the hospital within 6 hours. For continued care, we offer universal birth dose. The primary healthcare nurses visit daily to offer this as well, and we offer IVIG. Of course, no system is without challenges, and so for us, the challenges that we identified is that we have a very large migrant population. So we have to make sure that we are offering multilingual culturally tailored communications to make sure that the information is delivered properly. We're also making sure that we're offering point-of-care testing within the community to see what our rates are. We know who may or may not be infected ahead of time. We're building partnerships with our community leaders, employees, NGOs to increase screening in our informal settlements. We also noticed that we have some late antenatal care for the positive mothers between 2020 to 2024. We had about 30% of them presenting within late second to early third trimester. And so we want to make sure that persons are presenting the first trimester, not only for hepatitis B, but for general care within the pregnancy. So we're encouraging early antenatal care through these partnerships that we've been forming to our outreach and educational activities, so that we're increasing our bookings at first trimester. We also have another limitation we found is that we didn't have viral load testing in country, but we did have the reflex envelope protein, antigen E, that is done in country, but we are planning to introduce it through the National Public Health Lab. Because, one of the things coming out of COVID is that we have gene expert machines, so we're able to offer this testing in country. We found that there was also a gap in terms of follow-up of the infants at 3 months after vaccination. Around 9 months isn't a usual time for children to come back in for vaccination. But what we're doing is that we're putting that date for them to come back for testing on the vaccination card, and we're logging it in our system to say, this is a date to come back for testing for it. And also we've strengthened our staff capacity in terms of we have a dedicated nurse that is calling back these infants, and the nurses that are associated with the health promotion and advocacy unit, they're helping to call in the clients along with the public health nurses within the primary healthcare system. We also found that we had poor testing and treatment of partners. So as soon as we get the mothers in for their first antenatal clinic, we are encouraging them to have their partners come in along with them to get tested, not only just for hepatitis B, but also for the other infectious components. And because we saw all of the gaps that we're having, and we're having shifts in our protocols, our treatment protocols, our testing protocols, we want to make sure that we're increasing the capacity of our staff in terms of their knowledge gaps. So we're offering continuous medical education. We are printing the EMTCT manual, but also we created large laminated posters to place in all of the clinics. So it's like a quick look. So instead of you flipping through a book or trying to base on memory, you can just look up on the wall. You will see what the protocols are, and so you're able to follow the protocols. And that's the end of my presentation. Are there any questions?
Thank you very much, Dr. Clarke, for that presentation. We had a glitch, but you know what? It was excellent. Your presentation was good. And so we will now go back to the questions. I just realized, and my apology, I don't know if participants have access to the mic. If not, please go ahead and type your questions in the chat. Let me see if we have any additional questions. Leandro, maybe you could help me too, because Donna does not have access.
Okay.
One quick question here. I see it says, quick question, in your practice, are you experiencing an emerging challenge where antenatal mothers are refusing to have their screening test done? And what can we do? I'm thinking that perhaps this might be for you, Dr. Clarke. I'm not certain. But yeah.
So thankfully, we've not had that challenge, but we do have, on a large scale, but we do have occasional clients that have been hesitant with their screening. And what's important here is continuous counseling. So even if you don't get them screened at the first antenatal visit, which we advocate for, every single visit that comes, we are encouraging them to be tested at every single appointment that is there. So we've fortunately not had that as a large scale, but we do continuous counseling for those persons who are hesitant to have their screening done. And
Thank
that's
you.
why part of it is the pre and post test counseling is extremely important.
All right. Thank you very much. I'm looking to see if there are other questions. I think, Leandro, you had responded to some in the chat already, right?
Yes,
Yeah.
yes. But I think we also spoke about the questions that were in the chat. And yeah, I think we addressed everything.
Yeah.
If people want to talk, you can just raise your hand and we can allow the mic, because I cannot find the option to allow the mic for everyone. But if you want to ask a question, you can raise your hand and then we'll allow the mic. But otherwise, you can just write here in the Q&A or in the chat.
I don't see any raised hands. Okay, I see there's one, Catherine. Can you see her, Leandro? Maybe you could open her mic.
I'm seeing a question here regarding the co-infection here. In the case of a patient that is taking TLD, dolutegravir, tenofovir, and was tested, an HIV patient that was tested for hepatitis B, came back and came positive. So in that case, yes, the tenofovir is covering the hepatitis B as well. So no need to change the regimen for the treatment. You just need to be aware that whenever you need to change the regimen for HIV, in case resistance for tenofovir appears in the HIV in the virus, in the genotyping of the patient, you need to add the additional drugs, but you cannot remove the tenofovir. So, and then you need to change and to arrange the regimen. So you need to keep the tenofovir, even though they will not covering the HIV infection, but now you need to keep it for hepatitis B. And also you need to include and to add as part of the assessment for this patient all of the monitoring, all the tests that we've done. Even though the treatment is already being done and the patient has been treating for hepatitis B, you still need to assess the liver, need to assess to monitor the ALT, the APRI levels, and then to monitor for liver cancer and cirrhosis as well, and then refer the patient for specialized care if needed. But the treatment, yes, it's been covered, but that's the not only component. You need to be aware and to investigate further investigate the patient.
Thank you, Leandro. As I noticed, Catherine has her hand raised. Bacchus, I think it's Catherine. Oh, it disappeared from me. I'm not seeing it again. I'm not seeing any hand raised.
I've seen also a question here, not a question, a comment about Antigua, and I don't know if I got it right about the informed consent required for vaccination for the birth dose, and just to make sure if that's a written consent that is needed, because then it may be a barrier, and then you may reflect in lower coverage because sometimes people they are not sure about this and they may defer the vaccine, the birth dose especially, because they are not sure. Usually, of course, there is need to consent. There is a need for all procedures and now medications, everything that will be administered, including the vaccine, for an informed consent from the parents, from the family. But oral and verbal consent should be enough. And then, of course, you need to explain to those families the benefits. And that's another thing I didn't mention, but was in the final slide. You need to increase, very important movement and approach is to increase awareness of the benefits of the vaccine during pregnancy. So you're having a woman, you test the woman, even if they are negative, the woman is negative for hepatitis B, of course, you need to ensure that to explain what will happen at the moment of the delivery as part of everything that I explained on the obstetric side. Then you also recommend and explain about the vaccines, that the baby received the BCG in some places where they have the tuberculosis, and then the hepatitis B vaccine, and then the prophylaxis for the infection, the ocular infection, conjunctivitis. So all the package should be explained during pregnancy, so there's been no denial, or not denial, but they refusal to receive the intervention.
And if I could just also add to what you mentioned, Leandro, we always mention that EMTCT is very interprogrammatic. And so there is a clear linkage and close collaboration with immunization, so that both maternal and child health, at the ANC clinic and at immunization, the same information is being shared to the general population. I'm not seeing any additional questions here. I guess if we do not have any burning questions or concerns regarding this topic, we can bring this session to a close. I know, let me see if I can share. Donna had prepared a slide as it relates to, for us to do a quick evaluation before we leave today. Let me see if I can share it. Why am I not seeing my? Give me 1 second here, because I am also fumbling with my computer. Today, it's like technology is not on our side. So let me see if I can share very quickly. Nope, that did not work. Let me try this one more time. My apology. Okay, so let me see. Tell me if you can see the screen with the QR code. Are you seeing it? Hello?
Yes, Ms. Jones, we're seeing the screen.
Seeing the screen? So
yes.
I would just ask everyone if they could take a few minutes to access the evaluation and respond to it for us. We would appreciate it. Can everybody access the QR code? Is it coming up appropriately?
Yes, we can see it well.
Okay, and they're seeing the questions? We kindly ask that you complete the questions before exiting today. I would like to take this opportunity as you're filling out the evaluation. We thank you very much for participating in this webinar today. It is anticipated that the information shared today will significantly strengthen the response for hepatitis B for pregnant women and for the general population, while contributing to the overall response to ending hepatitis B as a public health threat. I also would like to take this opportunity to just inform that we are exploring ways to make the webinars and the trainings that we have been doing under the project, which I mentioned earlier, funded by the Indian Development Foundation. We would like to make it available on a dedicated website for as a reference and for share with others who were not able to participate in the sessions. We are continue working on this, and we will inform accordingly as to the updates and how we are progressing in this area. As we now come to the end of this webinar, the training for today, once again, thank you very much for your participation. I hope that the information presented, and most importantly, the experiences and the lesson learned from Turks and Caicos will able you to actually improve the primary prevention and treatment services for hepatitis B within maternal and child health. We certainly look forward to seeing you again for part 2 of this training, which will focus on the vaccination as well as the follow-up for the exposed infants. And of course, equally important is the surveillance to track and monitor the exposed infants. With that said, thank you very much for joining, and I now close this session, but we do appreciate your feedback. So your time in completing the evaluation form is greatly appreciated. So as you go back to your work, have a productive day and a wonderful and restful weekend. Thank you very much. And I now bring this training to a close. Thank you very much.